Hello, my name is Chris. I'm a retired Canadian pharmacist. Welcome to this 7-part series titled What Every Pharmacist in Canada Needs to Know About the Design and Teaching of Doctor of Pharmacy degree programs. This is part 4, Advanced Experiential Education. Advanced Experiential Education is full-time experiential education. The way it's taught varies from school to school. In the school that I'm most familiar with, it was 7 periods of 6-week training. Every 6 weeks, students moving between community and hospital and other forms of pharmacy practice. Starting the 4th year, I've had 3 years to gain experience in applying knowledge and skills in practice through their early experiential education. As such, it's reasonable to ask, at what level are they capable of performing at the start of the 4th year Pharmd program? At this point, I want to go back to part 2 of this series, the changing nature of pharmacy practice, and the fact that governments are asking professions, including the pharmacy profession, to do more to help overcome the healthcare challenges facing Canadians today. That was the whole rationale for the introduction of the Pharmd program, the Entry to Practice Pharmd program. The question is, has there been any evidence for improved patient health outcomes attributable to the entry-level Pharmd program? I'm not sure there is at this point in time. Certainly in recent times there has been the highly successful pharmacy-based immunization programs across the country, but that involved all pharmacists, not just entry to practice trained pharmacists. So again, I'm not sure that there's any evidence for the degree yet, but there is the challenge of making sure that new programs do come, and it will be potentially well based on the entry to practice graduates. Experience with vaccinations sets a template. It has to be in a community pharmacy setting. The number of community pharmacies compared to all other forms of pharmacy practice just make it common sense that to get high impact, it has to be in a community pharmacy setting. It has to be addressing high impact problems. Lots of patients not meeting treatment goals, lots of morbidity and mortality, as well as it must be easy to deliver whatever is done. It has to be easy to deliver. So I think it's reasonable to target chronic diseases, and I'll use diabetes as an example. Diabetes is suboptimal. The care of patients with diabetes in Canada is suboptimal. Multiple reasons for that, but one of the primary reasons is suboptimal self-care. Diabetes is one of the diseases where patients' own participation in their care is absolutely crucial. It also fits the other criteria I spoke about. Lots of people with diabetes, lots of morbidity and mortality, self-care, easy to teach in community pharmacy settings. I need to go back even further than I did a few minutes ago to the time when I was Director of Experiential Programs in the University of Colorado School of Pharmacy. I was sat in my office one day when the phone rang, and a physician was calling me, a physician I'd never heard of before. I didn't know them, but the purpose of their call was to demand that I put a community pharmacy-based self-care teaching program in the community pharmacy close to his practice site. What he wanted was a place to refer his patients to for self-care teaching. That eventually led to the creation of a statewide network of community pharmacy-based self-care teaching programs in Colorado community pharmacies. How did it work? Simple enough. The School of Pharmacy would send out an experienced clinical pharmacist to the site to initiate and initially operate the self-care teaching program. physicians, the local physicians referring their patients to the pharmacy. The local staff pharmacist, the on-site pharmacist, would watch over the experienced clinician's shoulder, but that dynamic was quickly switched, so it was the experienced clinical pharmacy faculty member looking over the shoulder of the staff pharmacist as they taught the self-care program. And when he, the experienced pharmacist, was confident that the staff pharmacist had achieved the skill levels necessary to teach the program without direct supervision, two things happened. He withdrew and went off to the next community to start from scratch again, though of course available at any time for phone calls, contact from the first pharmacy if something came up that they wanted to talk about. Secondly, the school began to feed fourth-year pharmacy students into the site such that they would teach the self-care program. The staff pharmacists would oversee it, but they didn't have the time to do all of the teaching themselves. The nature, I spoke about the 6-week periods of training for each student, so that every 6 weeks the student who was there delivering the program would leave, but be immediately replaced with another student, and as such a year-round service was maintained in that fashion. The program itself comprised 6 lessons, 1 hour per lesson per month. Various forms of self-care, talking about diet, lifestyle, medications, and so forth. At the end of the 6 months, the healthcare outcomes, the objective measures of care were compared with the starting baseline measures of care. And there was clinically and statistically significant improvements in healthcare outcomes. There was better control of blood sugars, better control of blood pressure, and better control of blood lipids. At the start of the program, the patients coming to the pharmacies had, on average, a 5-year history of diabetes. And yet, at that 5-year time point, they were still a long way away from reaching their treatment goals. And yet, within that 6 months of the pharmacy-based program, many of those patients reached treatment goals, and many others made significant steps towards reaching their treatment goals. It's reasonable to expect students who have had the experience, a successful experience, of teaching health self-care programs in community pharmacy settings will have the skills and the self-confidence to offer those services after graduation and throughout the rest of their practice careers. I'm not aware of any such programs in Canada, and I believe the reason for that is poor Pharmd curriculum design. Canadian Pharmd students reaching the start of their 4th year have not been trained to offer self-care services in community pharmacy settings. As such, I think it is a responsibility for the practice community to drive a systematic overhaul of current Canadian entry to practice Pharmd programs, such that 4th year students starting their 4th year are competent to offer healthcare services that improve the healthcare of Canadians. I have, throughout the series, offered quotes from the literature, and my choice for this episode in the series is a simple one, a short one. Quote, "Pharmd curricula that stifle creativity and innovation," end of quote. What we're seeing here, in my opinion, is the maintenance of the baccalaureate teaching methods in the Canadian Entry to Practice Pharmd program, in preference to the evidence-based educational methods recommended for teaching Pharmd programs. The problems of the old program are simply being carried over into the new one, stifling creativity and innovation. As I get towards the end of this presentation, I'll spend a few seconds talking about the upcoming episodes 5, 6, and 7. That's where I'll spend a lot of time talking about the integration of the teaching methods. So that's upcoming in the next three parts of this series. It's as I've done in all previous times for you to look back on your own training and ask yourselves, would you have benefited if you had been given the opportunity on a frequent and regular basis to spend time in pharmacy practice settings with your sleeves rolled up, again, for the duration of your training program? If the answer to that is yes, then I'll encourage you to view all parts of this series. I encourage you to dialogue with your colleagues. Talk to your local, provincial, territorial, and national pharmacy organizations. Talk to your local pharmacy school. Talk to the accrediting body. Talk to anybody who will listen, but to drive improvement in the teaching of entry to practice Pharmd programs in Canada. Thanks for watching. Your questions, comments, and requests for supporting documentation are welcome.